Assalamu alaikum and welcome to this lecture on endometrial cancer. You should have looked at the lecture on perimenopausal bleeding or the management of perimenopausal bleeding before you come and watch this lecture on endometrial cancer, as some of the things that could have been discussed in this lecture have actually already been discussed in the perimenopausal bleeding lecture, and I'm not going to repeat myself a lot in this lecture. So, first of all, what is endometrial cancer? Yes, endometrial cancer is the cancerous growth within the uterus, in the main corpus of the uterus, affecting the endometrium and from endometrial cells. What is the prevalence of endometrial cancer? So, endometrial cancer is more frequent in postmenopausal women than premenopausal women, although it can occasionally occur in the premenopausal age group. So it can occur in the premenopausal age group. The majority of cases fall after menopause. But they are not. But endometrial cancer is not like vulval cancer. It's kind of a cancer that is even more common in the older the women get. No, the peak age is in the kind of 7th decade or 7th to 8th decade. So between 65 to 75 is mainly is the main incidence for endometrial cancer. So as I said, 75% are postmenopausal and only 25% are premenopausal. And these are usually towards the end of the reproductive age, not beginning of the reproductive age. So here you find a little illustration of the number of new cases and also in the number of deaths. And what do you see on this figure? Just have a kind of brief look at it. Yes, you see a relatively high number of new cases, but a constant and actually quite small number. So compared to the incidence, an actually quite very small number of deaths. Why is this? Here's another such paragraph, which shows again the incidence rate and compares this to ovarian cancer and cervix cancer. And you can see also with ovarian cancer, you see a constant increase. So the older the women get, the more likely it is for them to have ovarian cancer. But here with endometrial cancer, the peak age is really above 60 to 70, and after 75 it starts to decline again a little bit more. However, altogether, endometrial cancer is much more common than ovarian cancer. And here's another such picture. This is regarding the mortality rate. You see endometrial cancer, cervical cancer, and ovarian cancer. And here you find a different picture. So if you go back to the previous picture, looking at the incidence rate, you see that the incidence of endometrial cancer is much higher than ovarian cancer and also much higher than that of cervical cancer. But the mortality rate of endometrial cancer is not much higher is only slightly higher than cervical cancer and is actually much lower than ovarian cancer. So here you can see again this difference between incidence and death rate or mortality rate, and this is really due to the fact that it presents early, has early symptoms, and with early presentation it is usually easy to pick up early and have a good chance for cure. This is exactly the opposite from ovarian cancer, when ovarian cancer often presents with non-specific symptoms that can be there for a long time and that cause delay not only for the patient presenting to the doctor but also from the doctor to make the diagnosis. And this delay will kind of cause the patient to present in later disease stages. than with endometrial cancer, which makes early symptoms. With cervical cancer, you also see lower mortality rates, and this is, of course, due to the effective screening program and early uptake of pickup of cancerous changes. So what are the symptoms that you find with endometrial cancer? You can stop this video now and write them down if you like. So the main symptom is abnormal vaginal bleeding. The flagship symptom is postmenopausal bleeding, but there's also other forms of abnormal bleeding. You sometimes find intermenstrual bleeding. You might find heavy vaginal bleeding. Postcoital bleeding can also be associated with endometrial cancer. Irregular vaginal bleeding, abnormal watery or blood-tinged discharge or vaginal loss can also be a sign. Pain might be a sign, but it is actually rare. It is not usually common for women to present with pain as a sign for endometrial cancer or a symptom for endometrial cancer. Okay, so let us look at the risk factors for endometrial cancer. Write them down now. Hold the video and write them down. The main risk factor is the estrogen effect on the endometrium. Okay, and this is associated with obesity, with a late menopause. The main effect is unopposed estrogen, which might be iatrogenic if women are given estrogen treatment without progesterone to kind of oppose the estrogenic influence onto the endometrium. And estrogen has got a mitotic effect and causes more mitosis within the endometrium, and this then can lead cells to kind of transform, kind of have mutations and finally become cancerous. Whereas progesterone opposes this mitotic index or this mitotic activity. Therefore, you need in the endometrium a balanced action of estrogen and progesterone to be safe. Anovulation can be one factor. Anovulation, as you know, causes a more exposure to estrogen. And obesity is because it causes the subcutaneous conversion of androstenedione to estrogen. For many, many years, it has been believed that tamoxifen is a major cause for endometrial cancer. Tamoxifen, of course, given after breast cancer. But really, that has been controversial. Recent analysis of data from the surveillance, epidemiology, and end results data, which is a database kept in the United States, where all kind of cancerous cases, their presentation, treatment, survival, and so on is registered. And this data does not confirm that tamoxifen is actually associated with endometrial cancer at all. We know it is associated with causing hyperplasia, with causing maybe polyps and things like that. So it can cause abnormal bleeding. It can also cause such things as polyps and so on. But it is probably not actually responsible for endometrial cancer. But family history is a huge influencing factor for the risk of endometrial cancer. We have some phenotypic characteristics here. There's type 1, which is the classical form of endometrial cancer, which is kind of associated with obese women, which are nulliparous. They have often suffered infertility due to anovulation. Maybe they have hyperlipidemia, maybe hyperinsulinemia. So there's a kind of relationship to the metabolic syndrome X here. Often these are also found to have well-differentiated endometrial carcinomas with good prognosis. There's a second type, which is very rare. So this is not the typical type, and it's a rare type, which affects thin, multiparous women who are often from African descent. These women, unfortunately, suffer a poorly differentiated carcinoma, and they have generally a poorer prognosis. So how do you diagnose endometrial cancer? The main way of diagnosing endometrial cancer is the transvaginal ultrasound scan, and especially in postmenopausal women, this can be very useful. It is a way of looking at the endometrial thickness, and if the endometrial thickness is above a certain kind of limit, which is usually 4 millimeters, sometimes 5 millimeters, if it goes above that, then there's a high risk that this woman has got endometrial cancer. And this then will have to be investigated with a biopsy. And we discussed in the perimenopausal lecture how biopsies can be taken, and that they can be very easily taken by a prepared biopsy in the outpatient clinic. These are, on this slide, you see transvaginal ultrasound scans from endometrium. On the left, there's a normal uterus with a normal endometrium. So this is a transvaginal scan. And then on the next two slides, you see a very thick endometrium. And you can see it on the lower picture with the two arrows. And on the upper picture, the one with the bright echogenic area is the endometrium. And these are well above 4 millimeters, but you have to always actually measure them so that you can be certain and you do not get confused with the zoom in the ultrasound picture. So what sort of histology do you know of endometrial cancer? How do you get the histology result? And I said I'm not going to kind of repeat myself very much. This is actually this has actually been covered in the perimenopausal bleeding lecture, and there we have said that you can do it by prepared biopsy with hysteroscopy, or if necessary with dilatation and curettage, but mostly there's no need for using this technique of dilatation and curettage. Hysteroscopy, I show you some pictures now. On the left side, there's a normal hysteroscopic picture. You see a normal cavity, and this is obviously a postmenopausal cavity. You can see that as the endometrium is pale and thin, and you see both and small. The cavity is small, and you see both tubal ostia, the small dots at the top of the picture. And then you have three pictures, and all of them show thickened and very suspicious looking endometrium. So this is very suspicious. Of course, you cannot be sure until after you've taken your biopsy and the pathologist has had a look at it. But these pictures look very suspicious. So now we come to the histological findings, and you can find different kind of types, of course, of endometrial cancer. Most are adenocarcinomas. You find, though, the endometrioid adenocarcinoma is the most common type. You also find adenoacanthomas. Those are adenocarcinomas. They have a benign squamous cell component. And you find the adenosquamous carcinoma, which has a malignant squamous component, which is an adenocarcinoma with a malignant squamous component. But the grading or the prognosis is directly related to the grade of the adeno component and not to the grade of the squamous cell carcinoma. You also find clear cell carcinomas in this group of endometrial cancers, and these are around 10%, and these have a poor prognosis. This is similar as clear cell carcinomas in the ovary and also in the goblet cell carcinomas in the stomach. They do have a poor prognosis. Then you find papillary serous carcinoma, and these also have a poor prognosis and are quite rare. So how do you treat and manage these patients? You usually you do a staging of these cancers usually after surgery. So in stage 1, the tumor is confined to the uterine corpus. If it 1A means that it is invaded into the myometrium less than 50%. 1B means more than 50%. You have type 2, in stage 2, the tumor invades the cervical stroma, but does not extend beyond the uterus. In stage 3, you have 3 subtypes. A means it's an invasion of the serosa and the uterus or the adnex. B means the vagina or parametrial involvement, and C means pelvic and para-aortic lymph node invasion or metastasis. Finally, you have stage 4. For A means invasion into the bladder or bowel, and for B means distant metastasis. And these are some pictures that are supposed to kind of illustrate this a little bit. Here you can see stage 1A and stage 1B. So stage 1A is invading the myometrium, but less than 50%, and stage B is reaching deep into the myometrium, above 50%. This is important because in the deeper invasion of the myometrium, the risk is much higher that the lymphovascular space is also invaded. Here you find a picture illustration for stage 3. You see stage 3A. There's an invasion either in the ovary or in the vagina or in the para-aortic lymph nodes. So this is to make it to illustrate this to you, and this is an illustration of all kind of 4 kind of different stages. You can see stage 4, stage 4A invasion into bladder or bowels, and stage 4B is metastasis, hemolytic, hemorrhagic metastasis. So, in the managing endometrial cancer patients should be done similar to all cancer patients by a multidisciplinary team. Part of this multidisciplinary team have to be a gynecological oncologist, a medical oncologist, a gynecological radiologist, and a gynecological pathologist. And it is very important so that the kind of decision can be made what the adequate treatment is. So let us look at tools of staging. We have MRI and CT scan again to kind of stage the endometrial cancer before surgery, but the final staging will be done before after surgery with the kind of results from that. So the mainstay of treatment for endometrial cancer is surgery, and this includes a total abdominal hysterectomy and bilateral salpingo-oophorectomy for surgical staging. So sometimes also some lymph nodes will be taken from the para-aortic lymph nodes to kind of make a staging of that, to make staging possible. This picture on the left-hand side shows you what is meant by total abdominal hysterectomy and bilateral salpingo-oophorectomy. You can see the picture on the right, labeled with B, is exactly what is described by that. A radical hysterectomy, we talked about this in the cervical cancer lesson. And the cervical cancer lesson, we talked about radical hysterectomy or Wertheim's hysterectomy, and you can see the difference to the total abdominal hysterectomy and bilateral salpingo-oophorectomy. The radical hysterectomy does not necessarily include the adnexa. For the cervical cancer, the Wertheim's hysterectomy does not include the adnex, but it includes the cervical tissue and the parametrial tissue, and also the upper cuff of the vagina or vaginal cuff. So in all, you will do hysterectomy in all of the stages, and only in the later stages and in recurrent disease will you also add chemotherapy and radiation therapy. So what is the life expectancy after following endometrial cancer? I can hear you now say it is according to stage, and you are correct with that. If it's so, the life expectancy is very good. If it's or 5-year survival rate is very good in kind of stage 1, and then it decreases as similar to all cases. The good thing for endometrial cancer is really that it presents mostly early, because women notice abnormal bleeding. They notice this is not right. I have to do something about this, and they go to the doctor early on. And then the doctor also usually is familiar with postmenopausal bleeding or abnormal vaginal bleeding being something abnormal, and investigates further. So prognostic factors are, first of all, the stage, so especially the myometrial invasion, as deeper myometrial invasion is means that there's a higher chance of lymphovascular space invasion, and if you have lymphovascular space invasion, you also have the risk of lymphatic metastasis. The tumor type is important. So clear cell carcinoma has a poorer prognosis, and so have serous papillary carcinoma. The grade is important. So well differentiated tumors have a better diagnosis than poorly differentiated carcinomas. And also the peritoneal cytology is important. So a positive cytology equates to poorer prognosis. The peritoneal cytology is not included in the staging of the disease. And adnexal metastasis, of course, they also mean poor prognosis. With adnexal metastasis, the risk for hemorrhagic hematological metastasis is much higher, or distant metastasis is much higher. The peritoneal cytology has to be taken with all surgery for any gynecological cancer, so all abdominal surgery for any gynecological cancer. That means that after opening the abdomen, if there's ascites in the abdomen, a sample of the ascites is taken and then sent to the pathologist for cytology. If there's no ascites, then 20 mils or 10 or 20 mils of normal saline is injected, put into the abdominal cavity before anything else is done, wriggled around, and then taken out, and also sent for cytology to the pathologist, so to see if there's any cancerous cells in this fluid, so in the peritoneal sample. So if you have any questions, of course, I cannot answer them now directly. I hope that please write them down on a piece of paper, and I hope we will get the chance to have a video conference where we can discuss any questions that you might have from any of my lectures. Thank you very much for listening, and I hope to see you soon.